Hello, my name is Dr. Bobovnikov and I am working for UTHealth with the Department of Cardiothoracic and Vascular Surgery with affiliation with Memorial Hermann Hospital, Texas Medical Center. And today I want to introduce you the technique of total arterial revascularization in coronary artery bypass surgery. What is the objective of CABG? We all know that we need to relieve the angina of patients, the prevention of myocardial infarction, and preserve left ventricle mechanical function of the heart, and as well improve survival of this patient. And the goal is complete revascularization of bypassing all vessels that have at least 50% stenosis inside the vessels. And the patency is enhanced by grafting larger vessel with good runoff. Improved patency rate correlates with better clinical outcome. And which conduits we can use for the bypass surgery? Up to 3 to 12% depends on the quality of the vein, may be already included. And nearly all veins develop further intimal thickening within 4 to 6 weeks, which may reduce the lumen by up to 25%. But vein grafts, atherosclerosis may begin as early in the first year after the surgery, but it's fully developed only after 5 years. And therefore we know that in 5 years up to 50% of graft will be closed. And in 10 and 20 years, about 60% will be closed as well. 2/3 of this lesion will have a luminal diameter reduction by 50% or greater in this consecutive 10 or 20 years after the surgery. Therefore, the surgeons looked for another best available graft. We tried to use the radial artery, we tried to use a gastroepiploic artery, but the further one didn't find any clinical significance because we saw there is very bad outcomes of these patients who had a graft with using the gastroepiploic artery. But from the other hand, we have the internal thoracic artery, and this is unique artery that endothelium of this artery itself unique as well, with a significantly higher basal production of vasodilatators, nitric oxide and prostacyclin. And why not to use both of them? What not to make these configurations and actually to improve long-term survival of this patient as well and the quality of their life. And many studies were done in different countries, and already 20 years ago colleagues from Israel found that the last 6-9 millimeter proximal to the internal thoracic artery bifurcation is less prone to vasospasm and has greater relaxation response to nitroglycerin and more vasospastic distal parts post-bifurcation of the internal thoracic artery, but we don't use them for the bypass grafting and the site of anastomosis. And we know that for 15 years, about 85 to 92% of left internal thoracic artery grafts patent, and it was found and published in European Journal of Cardiothoracic Surgery in 2004. From other point, we have another artery that widely available. This is radial artery, but we know that radial artery is very prone for spasm, and there is a little advantage versus vein graft for long patency and improvement of outcome. Therefore, many studies and publications show the radial artery patency is good as long as a lesion in the grafted vessel has more than 80 to 90% stenosis, and the runoff of this vessel is good. But it's widely available graft, and some surgeons use that, and actually we use it here as well, but only for clinical and medical indications for some patients. So let's talk about the usage of bilateral internal thoracic artery or single internal thoracic artery. And we know that Buxton in 1998 already published 10 years survival improvement in a patient who underwent coronary bypass surgery with usage of bilateral internal thoracic artery, and it was 87% versus 71% with patients who got only one internal thoracic artery. And it was approximately 1,500 patients in each group. And Lytle in 1999 showed the same results and showed the improvement of patient survival, statistically significant, with the usage of bilateral internal thoracic artery, and showed this improvement on long-term survival. Myocardial revascularization using bilateral thoracic arteries improves long-term survival, freedom from myocardial infarction, freedom from recurrence of angina, and freedom from percutaneous coronary angioplasty and repeat operations. And this Bruce Lytle showed it published in Journal of Thoracic and Cardiovascular Surgery already in 1999. And we see that actually in the first 10 years, if you compare usage of bilateral internal thoracic artery versus single and vein grafts, show the difference significantly become apparent only after 10 years of the surgery. Majority of vein grafts will be already closed, but it showed in study the bilateral internal thoracic artery is still open at the same time, and patients definitely benefit in 20 years. More than 30% of patients who got the bilateral internal thoracic artery will be alive. There are many publications that came out in the multi-center studies and retrospective studies and double-blind studies, and all of them show that total arterial revascularization should be encouraged in patients with reasonable life expectancy. That means if you have a patient that his life expectancy more than 10 years, you definitely should consider to use bilateral internal thoracic artery in your surgery. But let's talk about what is the configuration and why we need to use that artery. Some people, some surgeons think that use of bilateral internal thoracic artery related to increased risk of sternal wound infection, especially in diabetic, elderly, and obese patients. And skeletonization definitely reduces the risk. There are many advantages of this technique. First of all, it gives you the advanced length of the internal thoracic artery, about the 7 centimeter longer, that you can reach very distal lesions. Here we can see on this slide that the study was done on patient who underwent internal thoracic mammary artery harvesting by regular techniques, that mean pedicle and skeletonized. And we see there is no problem with the revascularization of sternal bone after the usage skeletonization technique. And sternal wound infection before skeletonization of the internal thoracic artery reached approximately 4.5% of patients, and after the skeletonization of internal thoracic artery, only 1.7% of patients had sternal wound infection. But in our days, using the microclip technique and less usage of cautery, even more decrease the risk of this infection. There are many configurations that we can use both internal thoracic artery. We can use it in situ and bring it via transverse sinus to the circumflex marginal coronary arteries, or we can use like a free graft right internal thoracic artery and combine with a T-graft to left internal thoracic artery and create as approximately 3 to 4, 5 anastomotic site on the left heart, the LAD territory and circumflex marginal coronary artery territories. Composite arterial T-grafting causes splitting of internal thoracic artery flow. The amount of flow supply in each region depends on severity of coronary artery stenosis. A study published in Japan that included 362 patients with composite T-graft, competitive flow was found in almost 15% of the composite grafts patients, and graft occlusion occurred only in 3.6 50% of this patient. Therefore, we are looking for use this technique mostly for people who has more significant stenosis in both territories, LAD and circ. In these pictures, we can see how we bypassed using bilateral internal thoracic artery and how this artery is still opened mostly for more than 5 and 10 years. There are many types of composite grafts, sequential grafts, T-graft, in situ cross graft, sequential anastomosis, and only 1.7% of this patient coming back to cardiology to looking for repeat revascularization or redo surgery. Surgical techniques, actually they're very simple, but they require a little bit more surgical skills and a little bit more learning curve. And here you can see anastomotic techniques. They use the diamond grafts or sequential grafts, how to do the incisions and arteriotomy in coronary artery, and how long it has to be an anastomotic site, how to measure the distance between sequential graft, how long has to be internal thoracic artery. To prevent tension between anastomosis, after filling the ventricle with blood, the length of the internal thoracic segment between anastomosis should be 5-10 millimeters longer than actual distance between coronary arteriotomies. Revascularization of the right coronary system actually didn't prove any advantage of using right internal thoracic artery in situ to the right coronary artery versus saphenous vein graft, and they have actually very compatible patency rate for as long as for 10 years. Therefore, if we can revascularize the left heart with the bilateral internal thoracic artery, we will definitely benefit this patient.